Assalamu alaikum wa rahmatullah. Sabah al khair, and a very good morning to you all. Thank you very much for giving me the opportunity to be amongst you. I'm not sure if there are many surgeons in the room, so I do feel overwhelmed. So bear with me. I'll try to be as intelligent or half as intelligent as the previous speakers. My name is Hazem, consultant bariatric surgeon. I have the greatest of pleasure to be working alongside my colleague, Dr. Wael at Royal Khalifa Hospital. And I'm here to talk to you about a subject which I've spoken about so many times, a subject so close to my heart, that have witnessed a lot of evolution in the last 5 years. We've been dealing with obesity for several years, and since the 70s of the last century, we've noticed that the obesity figures had nearly tripled globally. At the beginning, we thought obesity is all about eating too much and not moving too much. But we've come to know that obesity is such a complex, integrated disease, and no two individuals with obesity have got the same causes. There are various factors leading to the development of obesity. We've also come to know that obesity is a disease that affects us from head to toes, whether it's metabolically, as mentioned by the previous speakers, mechanically or mentally. I can't think of any organ system that is not affected by obesity, and I've just come to know today from listening to the previous speakers that other societies are recognizing obesity as a core or stimulus for many other pathologies. What we also come to know about obesity is that most conservative treatments of obesity would fail on the long term. On the left side of your screen, you see all of these trials that looked at optimizing patients' diets, fitness level, and exercise. And what we could see, nearly all of them would fail on the long term. And at one point, we used to blame the system or the patient, but what we've come to know that there are biological adaptations in our body that would make us more prone or make obesity more prone to relapse. I always say the same example. When you're not dieting and you come to a dinner, everything looks fine. But when you're dieting and you're trying to lose weight, everything looks 100 times more sexier. And it's all to do with the fact that once you've got obesity and you lose the weight, or try to keep the weight on, your satiety hormones would go down, and your hunger hormones go up, and your basic metabolic rate would slow down. So say, for example, I would need 2,000 calories to maintain my weight. I develop obesity, my basic metabolic rate will drop to 1,400. If I lose the weight, my basic metabolic rate will not go up again to 2,000 and will continue to be at 1,400. So individuals with obesity trying to lose weight would always live in a chronic state of hunger to be able to keep the weight off. And this is the struggle that they face day in, day out. We, as bariatric surgeons, have done our very best to treat a metabolic disease mechanically. However, we have come to know that it's nothing to do with making someone eat less or vomit more. And there is more to the surgeries that we do than just reducing the volume of food or theoretically reducing the absorption. And these facts came to light when we started noticing that for individuals, for example, with type 2 diabetes on oral hypoglycemics, we do a gastric bypass. On nearly day 1 or day 2 of their surgery, they're off their medications. So we started seeing metabolic responses to our surgery that are independent for whether or not they have lost weight. And what we've also come to know, and when we compared the multiple surgeries that we do, the effects tend to be almost comparable. We have now published randomized controlled trials comparing a sleeve gastrectomy to a gastric bypass with a 10-year, 80% follow-up. We've come to know that the two operations give us almost comparable results for the control of diabetes, for the control of hypertension, dyslipidemia, which means that there is something more to the surgery. And surprise, surprise, it's all to do with the incretins. And incretins play an integral part of the effect of the surgery that we do. And what we have come to know as well is that those individuals with a more pronounced incretin response following their surgery are the ones who's going to lose more weight. Hence, the science of incretin has become one of the most spoken about topic globally. I've also come to know that incretins have been around since the 30s of the previous century. They were introduced in 1932 by a Belgian scientist. Back then, he believed that the incretins are intestinal hormones that are secreted by the body to help it regulate glucose after consuming a meal. And the two most commonly spoken about incretins nowadays that are widely used are the GLP and the GIP, both of which are secreted by the duodenum and the jejunal mucosa. And they play an integral part in regulating postprandial glucose. These molecules started being used for weight loss, for diabetes. And then we've come to know that they play a big part in weight loss. So how has things evolved? For many years, we've only had the one molecule, which is the GLP-1, available in clinical practice. And we've become very familiar with liraglutide and semaglutide. And more recently, we've got tirzepatide. Tirzepatide is a revolutionary man-made or engineered molecule that targets both receptors, the GLP and the GIP. And what you need to understand is that in its design, it resembles more the GIP than the GLP. So what the scientists have been able to do is capitalize on the benefits of the two molecules. It does not need dose adjusting for renal or hepatic dysfunction, and it's got a long half-life, so it can be administered once a week. And in this graph, you see how this molecule is almost an exact replica of our in-body GIP. The way these molecules work is they stimulate a cell receptor, then a cyclic AMP cycle starts intracellular. And on the left side of the screen, you could see that when tirzepatide is used, it's almost an exact copy of the GIP, and it's got a lesser effect on the GIP. And this, the scientists have turned to their advantage when it comes to the mechanism of action and the side effects. So, the next few slides will tell us how tirzepatide is different to semaglutide or liraglutide. When it comes to the mechanism of action, the most important organs targeted are the pancreas, and in the past we only had GLP, which only works for hyperglycemia. And what it did, it increased the insulin and reduced the glucagon. However, GIP would work for both hyper and hypoglycemia. So, whenever hyperglycemia happens, it stimulates the secrete of insulin. Whenever hypoglycemia happens, it stimulates the secretion of glucagon. And we've come to use this in our clinical practice for the treatment of dumping syndrome post-bariatric surgery, which have produced really impressive results. The second organ this molecule works on is the central nervous system. It induces satiety by stimulating both the GLP and the GIP. And while the GLP molecule would cause nausea and vomiting, when it stimulates the GIP, it can be having an anti-emetic effect. So theoretically, the likelihood of nausea and vomiting when losing tirzepatide is less. The stomach, it reduces the gastric motility. And the last organ system for which to work on, which has produced the most impressive results when it comes to weight loss, is the fatty tissue. Tirzepatide is the first molecule to target fatty tissue, increasing insulin sensitivity, blood flow, and the adipoinflammation. And this was demonstrated in the SURMOUNT trial when they've noticed that the majority of weight loss was through the loss of adipose tissue, not muscular tissue. So what do we have in summary? We've got an organ that has got the benefit of both the GLP and the GIP. It's very potent, first of its kind. It's got a long duration, is not affected by hepatic or renal dysfunction, and it helps us lose more fat than muscle. And this has been proven by DEXA studies. The other main advantage which we've noticed in our clinical practice is when we were previously using liraglutide or semaglutide, we've noticed that these patients, or the effect of the molecule, will fade at around 4 to 6 months. However, when it comes to tirzepatide, we've noticed that the effect will last longer. It's all to do to what happens at the cellular level. When we stimulate the GLP-1 receptor, we start the cyclic AMP pathway, but we also start another pathway called the beta-arrestin. And what that does is an internalization of the receptors. So the cell tries to protect itself by hiding the receptors. So people will develop tolerance. With tirzepatide, that other pathway does not get activated. And this would explain why we notice a prolonged response to tirzepatide compared to the one we used to have for liraglutide or semaglutide. You're all familiar with the SURMOUNT-1 trial, randomized multi-center clinical trial looking at placebo versus tirzepatide. They used it at 5 milligram, 10 milligram, and 50 milligram for up to 72 weeks. And for the first time, we do have a molecule that will allow us to lose nearly 22% of the excess weight. Keep in mind, real-life data are different. Real-life data would say it's about 16%. Having said that, that is still quite impressive. A lot of people raised concerns about the safety, and we got a lot of people asking us questions about these molecules causing thyroid cancer. In this Scandinavian study from 3 Scandinavian nations looking at around 118,000 individuals who have been taking treatments for diabetes. Some of them were taking the GLP-1, other of them were taking other molecules, their DPPP4. And they followed them up for about 3.9 years, and they noticed that the likelihood of developing thyroid cancer is not higher in both groups. And just for you to know, the tirzepatide label in the United States had removed the risk of medullary thyroid cancer. We get this quite often. It's causing us a lot of headache. For medullary thyroid cancer, I wouldn't use it, but it's safe to be used alongside other thyroid cancer. You don't routinely need to do a thyroid ultrasound prior to commencing treatment. And then we've got the other risk or worry that patients talk about, which is the risk of pancreatitis. Evidence had shown that the use of GLP-1 or GLP-GIP is actually protective against the risk of pancreatitis. People with obesity are more likely to have gallstones, more likely to have dyslipidemia, and at a higher risk of developing pancreatitis than individuals who have lost weight, whether with GLP or GIP. We need to be cautious with dose titration and try not to use it in individuals with pancreatitis. Unfortunately, all the clinical trials have failed to answer this question because individuals with history of pancreatitis were excluded from these studies. And then there's the other issue, which is better. We know from clinical trial for weight loss, tirzepatide is superior to other molecules available. Having said that, and as clearly mentioned in the talk of the speaker just ahead of me, not all individuals are the same. And we need to profile our patients to decide which is best for best. Use what's available in your hand, use what's best for the patient. The financial burden plays a big role, but I think it's only a matter of time before not everyone will be having the same treatments. And depending on the profiling of the patient, we'll be able to recommend which is best for which. For example, so far, we know that semaglutide is approved for MASH, it's approved for cardiovascular risk, and it seems to have superior results comparing to tirzepatide. Tirzepatide does not work on the liver. It's very effective for weight loss, but we still don't have evidence regarding its efficacy with other indications. The conclusion is, we've got in our hands very potent molecule. We're living an exciting era when it comes to the treatment of obesity. Read the evidence, make your own decision. Not all patients are the same, and not all patients need the same treatment. We're very fortunate, and the patients are fortunate, that we've got many molecules to offer them nowadays. This brings my talk to an end. It's been a real pleasure speaking to you all. Thank you very much. Cheers.